Hello, I'm Marina Parton. I'm a medical oncologist from the Royal Marsden Hospital, and today I'm accompanied by Andreas Makaris from Mount Vernon, also a medical oncologist. Today we're going to talk about supportive care and lifestyle interventions on Day 3, Webcast 7 of the ACP webcasts. Today we're going to talk about two studies, one of which is a supportive care study and the second is a dietary intervention study. Andreas, would you like to talk about the first study?
Thank you, Marina. It's been an interesting morning today at the San Antonio Breast Cancer meeting. This particular study was presented by Brian Leyland-Jones and looked at the long-term outcome of a study that looking at the role of erythropoietin in supportive care for patients with metastatic breast cancer. The background to this is that in the 1990s, agents which could stimulate erythropoiesis were developed and they started being used in order to treat anemia and reduce the requirement of patients for blood transfusions during chemotherapy. Additionally, there was also the hope that because oxygenation was going to improve, the treatment of cancer would also improve from these agents. Initial studies in head and neck cancer receiving radiotherapy or chemoradiotherapy were supportive of this. However, some of the early studies in 2002 suggested that there may be a problem with these agents when used to treat anemia during the chemotherapy. In a study which was called the BEST study, and it was erythropoietin versus placebo in metastatic breast cancer, an increase in mortality of the patients on treatment was seen, but with no difference in TTP. And interestingly, there was also an increase in thromboembolic events with the erythropoietin. As a result of that, the FDA predated that there would be a confirmatory trial looking specifically at mortality and time to progression for these patients. This was set up as a non-inferiority trial, and it took across many different countries, but largely it was done in third world countries, although the 80% of patients did come from Russia, Ukraine, or India. The reason for that was that it probably was unlikely that it would have been possible to do this in North America or Western Europe, given the concern about mortality at the time. Within this study, the patients who did take part, they had free erythropoietin, free chemotherapy, and free Herceptin, which was part of the reason that the clinicians and their patients took part. Initially, the primary endpoint was meant to be progression-free survival, with secondary endpoints of overall survival and time to tumor progression. The patients were randomized to receive either a standard supportive care for anemia, which is essentially blood transfusions, or they received a standard care, supportive care plus erythropoietin. And if we look at first of all the time to progression, the PFS was the initial endpoint to be looked at, but as a result of not being sufficient events, it changed to time to progression, and the investigator determined time to progression showed that in fact there was actually some excess of deaths of events of progression for patients receiving erythropoietin compared to the ones who did not. If we look at the survival, overall survival, again there is a small excess number of deaths on the patients who received erythropoietin. And these patients, when they were receiving erythropoietin, they did have fewer blood transfusions, which was to be expected because that was what was intended to be done. There was more thromboembolic events, but in both arms they were infrequent, and the difference was 2.8 versus 1.4. But really the main take-home message is that the study it could not show that the use of erythropoietin was not non-inferior, and therefore if it is to be used erythropoietin in clinical practice, we have to have to warn patients of a possibility of some excess deaths.
Thank you, Andreas. This was a surprising result. The risks highlighted in the initial study was really associated with thrombotic events more than anything else, and how that would affect mortality. The effects on TTP was a surprise to everyone. He briefly skirted up around as to reasons why that might be. Any thoughts on that yourself?
First of all, though, when it first became apparent that there may be a problem with the use of these agents, it was not just in breast cancer, but in other cancers there was worse outcomes were seen, apart from the need for transfusions, which is the obvious one that is being improved. These agents are stimulating the blood flows, they're stimulating oxygenation, and it may be that actually tumors themselves are being stimulated as a result of better oxygenation, although at the time it was hoped that the better oxygenation would allow better treatment, the treatment to be more effective, but maybe that's not the case.
So do you think as a result of this and some of the other studies in other tumour types, we're going to see EPO in the clinic at all?
Erythropoietin will have a role in the clinic, and for patients who are unwilling or unsuitable for blood transfusions, it may have a role in maintaining their blood counts and in maintaining quality of life. The excess of events and deaths is small, and it may be acceptable to some patients.
The next presentation was by Roche Pharmaceuticals on the final survival analysis from the WIN study. That's a women's interventional nutrition study evaluating dietary intervention as adjuvant breast cancer therapy. The background to this study, the 1990s, was the observation that women having an Asian or Eastern diet with low dietary fat intake had lower incidence of breast outcome and improved outcomes. The feasibility of achieving dietary fat reduction was looked at, and it looked as though an intervention would be possible within the context of a randomised trial. This study was a phase 3 trial evaluating dietary fat reduction and the influence on relapse-free survival and overall outcomes. In 2005, Roche Pharmaceuticals' team presented data indicating a benefit in relapse-free survival in these women with the dietary intervention. So the original study looked at largely postmenopausal women with early breast cancer who received standard of care at that time, including chemotherapy and hormone treatment. About 50% of women received chemotherapy, and most women received CMF schedule, as was expected at that time, and about 6% received taxane treatments. Most women, due to a Western diet, had a dietary fat intake of over 20% of their calories. These women, after completion of treatment, were randomised in a 60-40 manner between 1994 and 2001 to either have a dietary intervention or to have to go into the control arm where they had no specific dietary intervention, and the relapse-free survival was examined. The updated outcomes from this intervention demonstrated that most women did have about 30% of their calorific intake from fat, and with the dietary intervention it was possible to reduce this to approximately 20%, although the target intake of 15% was not possible, as about a third of women did not decrease their dietary fat intake significantly. As a result of this decrease in dietary fat intake, BMI was reduced in the intervention arm, and this was persistently shown in years 1, 3 and 5. The weight loss, although demonstrated over sequential years, may have not been persistent throughout all women, as the reported outcomes and dietary intervention assessments deteriorated in consecutive years, with only about 40% of women being compliant on their assessment questionnaires by year 5. The cumulative hazard ratio for death by randomisation group in all women at the 10-year follow-up mark demonstrated that between years 1 and 7, the hazard ratio was decreased, although this was not significant. Otherwise, after year 7, the hazard ratios became more or less indistinguishable between the two groups. However, an ad hoc subgroup analysis of estrogen receptor negative women demonstrated a benefit of dietary intervention, most noted in years 1 to 10. In this table, the hazard ratio is decreased to 0.58, and which is significant, and this is shown to persist. So potentially, in this ad hoc post-evaluation analysis, estrogen receptor negative women could have a potential increase in their median survival of nearly 2 years by implementing this dietary intervention over the first 5 years after treatment. So the conclusions of this study was that it is possible, by having a dietary intervention after treatment, to reduce the fat intake and to potentially affect weight loss in these group of women. It did not appear to affect outcomes in all women treated. However, in the ad hoc exploratory analysis in estrogen receptor negative women, it appears to be meaningful. Certainly in the context of the lifestyle changes and other intervention studies, weight loss and possibly increased physical activity, there may be multifactorial factors here which may improve outcomes. So an interesting study, Andreas. Looks as though a dietary intervention is possible, it's sustained, and may have a meaningful outcome. Something to take home to the clinic?
Yeah, I think this is interesting in that it's achieved what it's set out to do, that to reduce the fat intake in these women, and this was accompanied by loss of weight as well. And what you can see is some improvement in survival. We have to take this into context with all the other studies that have been done, and for the last 20 years there have been multiple trials done with change in diet and other lifestyle, and looking at the outcomes of women with early breast cancer. The results are inconsistent between them, but if you take them all together, to me there is sufficient evidence to suggest that we should be making lifestyle change into part of the discussion, at least, that we have with women on completion of their treatment. What do you do at the Royal Marsden? Do you?
Well, after completion of treatment, they have an end of treatment review, and they're directed towards a series of talks and some guidance regarding nutrition, exercise and diet. But we don't have a specific targeted programme for women who are of a higher BMI, for example, or follow-up to maintain any dietary or lifestyle changes. What about your side?
Well, at Mount Vernon, we have recently obtained some funding for some extra dietitian sessions. So we have put together a program whereby, based on women's BMI, they will have different interventions. Those who have a BMI of less than 25, or what they need to do is maintain their current weight, and they're given a booklet essentially. Those women with a BMI of between 25 and 30, they are offered the option to attend a class which is taken by a dietitian and a physiotherapist, and have discussions about dietary changes with the emphasis on weight loss and rather than a change in fat, and an increase in exercise. And while those women who are a BMI of over 30, they're having a more one-to-one discussions with dietitians and a higher level of intervention. And we just started this month with this program, and we'll be evaluating over the next year about how successful it is in able to maintain and reduce weight loss. I think part of what we need to take into account actually is that our treatments of breast cancer have changed since the study was done in the 80s, 90s. And so this was predated the time of Herceptin. Chemotherapy was different then. These patients had received CMF chemotherapy. The surgery may be more effective, radiotherapy more effective now. And but also the women themselves, maybe there will be greater obesity at diagnosis than would have been there. So we can only transfer what we've seen there to the present situation with some caveats. And I also think the chemotherapy, because we're using more taxanes and anthracyclines now, we're using more steroids as part of the antiemetics, and as a result of that, that is boosting weight. And
certainly, sort of exercise and dietary intervention can't be harmful for the women for the increased risk of diabetes because of the weight gain, the arthralgias because the aromatase inhibitors are being used so much more. So the increased exercise would help there. So certainly, if not specifically for breast cancer-related outcomes, there'd be global outcomes that would be beneficial to them. And of course, treatment-related fatigue as well.
But the study looked at breast cancer survival. It did not look at breast cancer recurrences because it was more difficult to obtain the information for this. But in some ways, it doesn't really matter what the improved survival is from. And if we're seeing less deaths, that's good. Yes. And it could be coming as a result of fewer breast cancer deaths, but it could be coming as a result of improvements in other measures, such as heart disease. And I think that nowadays, when we expect that more than 70% of women with early breast cancer will be cured of their breast cancer, it's actually, we should be thinking about the other aspects of those women's health.
Absolutely. So, in conclusion, from these two studies, really, it looks as though there's a limited role for erythropoietin or EPO-stimulating drugs in the clinic. And, of course, there would still be an ongoing need for certain specific patients. And dietary intervention appears to be beneficial, possibly in ER-negative patients, although that's not been demonstrated in other studies, and the mechanism of which doesn't appear to be very clear. But certainly diet, BMI control and exercise overall appears to benefit most women either in immediate treatment-related effects or long-term global health outcomes.
I would agree with your conclusions on that. Thank you.